so I think actually, Sarah, your comments are kind of a great segue into doing a little bit deeper dive of what we've learned from the folks that Mark and Siggy have talked to who are in the room with us today. So Mark and Siggy, if you want to maybe dive a little bit deeper into some of the things you heard, and we can get the conversation going around the different models that we know are in practice and how we can continue to scale those and disseminate them to other ACCC members.
Okay. Actually, Laurie, it's funny, I did a literature review, so I guess I reviewed your literature, things that you have put out there, so it's incredible to have a face to the person. But one thing I can say is, as I was doing the literature review and listening to you and looking at stuff that we have done, there are tools out there that are self-reporting tools for patients that you can just give a patient and have it pretty much given to everybody. Those are text responses, so they can, it's almost like a daily calendar, a daily report that we have asked. I can tell you that I use this at the Vida for patients who started on home dialysis. And, you know, it's a very cumbersome thing and they have a whole lot of issues with it. And we just ask them every day to just write a little text to themselves. It goes to us, but what's going on with them every day. You find that you start finding patterns that are the same patterns throughout the entire population that you're treating. And those patterns can give you then the ideation of how to move on to something more like AI or automated. So just to put it out there, it's an opportunities and those already exist in the market. And I just wanted to put it out there. But one thing that I can say that is a common thing, right, is to, like you're saying, not to overdo it and not to be too intrusive on the patient or too intrusive for the physician at the same time as we're trying to figure out the right kind of level of care. I find those kind of programs to be a little bit easier to disseminate. Go ahead.
Some of the things that we heard in our interviews that were really interesting, and Sarah actually just touched on some of them, is not to become so intrusive that you start to alter the patient behavior or patient physiological responses because of just the abnormal sleep patterns and other issues that are coming up. And that's obviously very important. The other thing that we gathered was, again, this issue of sensitivity, particularly in genetic counseling, as you're disclosing some information to a patient, how you have to really read their reactions and guide the conversation accordingly, that there was a real need in that area to utilize a face-to-face assessment of what's happening with the patient. I wonder, though, whether or not the clinicians that are engaged in this, other than their inherent people skills, have any formal education or training on how to guide those conversations when somebody is completely shocked or breaking down because they have the likelihood of a major disease state coming their way. In fact, that's a question I'd like to ask the group, especially the APNs or RNs or others. Do you get any kind of orientation and training on how to, I know that genetics counseling is actually a specialized field in itself. By the way, who here is actually a genetics counselor? Anyone? Okay, but it would be interesting to know if you guys get any kind of background orientation toward how to present this kind of information. Has anybody gotten anything along those lines?
Well, I did a fellowship at the NIH in genetics. I'm not a genetics counselor, but I did. And one of the recommendations was that this type of information should not be relayed to a patient except by a genetic counselor. That is where it should come from. And that's why there's been a lot of concern about some of this. You buy the kit at the drugstore and you send it in. So yes, because we were talking about stuff, for instance, like Huntington's disease, people finding out that they had that gene. But even I think with the BRCA genes and stuff in oncology, and there's a lot of misunderstanding in the public. And so it was just pretty much that really ought to, the first discussion of the results should come from a genetic counselor. And then after that, it can move to other providers who certainly have knowledge of genetics, but who aren't the counselor. But the genetic counselor has the skills to kind of know how to respond to the patient's concerns. I don't know how other people.
We did not have the opportunity to specifically interview a genetics counselor during the interviews, but people who obviously were working with them. In general, they do have these skill sets then that they are formally trained in or certified in. Okay. Yeah.
We've had a cancer genetic counseling program for 20 years, so, but it's an evolving field. So whereas in the old days, up until just a couple of years ago, we had the capacity for, and this was a rare situation, to every patient who was being tested to have a pre-test counseling visit and a post-test counseling visit. It's really almost impossible now. The number of GCs that are training is not large, and the indications for hereditary testing have blossomed. So currently, it's now all metastatic breast cancer patients, all high-risk prostate cancer patients, and all pancreatic patients, and all ovarian cancer patients. There's almost no program, maybe outside of MD Anderson, which has enough GCs to do that. So we've had to modify. So telehealth and telemedicine for genetic counselors is a great application. Just what we're doing we've now trained providers, and we've actually developed videos to do the pretest in those populations. And the GCs are talking to them only when there's a positive result.
Mm-hmm.
And face-to-face through telemedicine is a good way to go. They do get a lot of training in their master's programs in how to provide the news. And so they have that experiential approach.
But you're finding there's a shortage of GCs, and therefore the use of telehealth helps to make that resource more efficient.
So what's happened is, well, my own institution, we're a good farm team for the commercial. 2 out of my last 3 just went to Myriad and Ambry, and I've trained about 5 others. And they love that because they can work from home. So the commercial companies actually do now have telehealth, but again, it's not under your control, so it's a little bit dicey, but we have to use it.
Yeah.
And for those who increasingly, there'll be not enough GCs, just like there's not enough providers, and more indication for testing. So we need a new model.
Yeah.
And this is a great model.
Were you going to say something?
I had to do a justification for a new position, a new GC. And in doing some of the literature and review, there's only 4,800 GCs out there in the United States. 4,800, the number is so low. And so when we talk about providers being needed to be there, and then all of the guiding forces from our Commission on Cancer, all of the new things from NCCN that tell us how we have to do things and deliver this information by these professionals, and that, you know, you got to go put things back in the patient perspective. If that were you sitting on the other side, you want a professional to be able to give you that kind of information. Like you choose your surgeon, like you choose your medical, like your GC is also very, very important to what can happen. So, and there's only so few of them. So this is absolutely perfect way to be able to get patients to the right GC.
The other thing we have really struggled with, I'm working with our genetic counselors at UVA, and we actually had 2 oncology specific genetic counselors, which made 4 for the western half of Virginia. 1 has since left to go to the eastern half of Virginia in pediatrics. So our biggest struggle came from 2 different places. One was within the last year, they were finally considered LIPs in Virginia. The other issue is that CMS doesn't consider them LIPs. So reimbursement is near impossible. So to compound that, and there are some academic centers that this is not the case, but there are some like mine that do not value genetic counselors enough to pay them enough to retain them. And so it's not a field that a lot of people want to go into because it doesn't pay well. Their only option is to go to these labs like Myriad because they will pay and they can work from home and they have a broader net. And they can also say no, they can turn off their computer at the end of the day and they don't have a more caseload. So there's a lot more that has to be fixed with genetic counseling before it really becomes something that's doable. Telehealth helps. My particular genetic counselor I'm working with right now actually is having a hard time with telehealth because it's on top of her in-person patients.
Mm. Yeah. That actually is an interesting point to bring up too. What we have found broadly in the more successful programs around the country and Mercy is a good example of this, is that when organizations dedicate staff specifically to a telehealth application, the results tend to be better. When they are splitting their rounds up between seeing some patients online and then trying to make rounds, we see frustration and inefficiency start to reemerge. Now, volume drives some of this. Sometimes it's just not practical or possible. At Vanderbilt, there's not that much activity yet to make sense of a dedicated staff. I remember I asked you that question. But ultimately, if you can get there, you will find that the performance of your telehealth programs consistently will improve when you kind of dedicate staff just to that medium and don't ask them to do rounds.
Well, you don't dedicate just staff in one place, but you create an overreaching organization who is responsible to disseminate telehealth, and you guys are all pulling into your resources together, right? So if you think about a great example for that is Telestroke. You can see a group of neurologists who are actually taking care of 135 hospital systems, but there are only 6 of them sitting in one place doing this. And all the hospital systems are paying into it. So each of them have to pay only $20,000 a year instead of $400,000 a month to have a stroke neurologist on staff. So you think about that on pooling resources, right? You're talking about genetic counselor. What if you created a super system of genetic counselors who can help all of you guys, but they are, everybody's sharing in the cost, and so they are available to you virtually whenever you need them, but they're not yours specifically all the time. I think that that's something that, by the way, I haven't seen that. When we looked at this study and others, I didn't see that what we call pooling of resources happening in the oncology space as much as I've seen it in other spaces. You'll see it very well in other spaces. Neurology is one of them, but where you will get specialists who are pulling in together to serve a larger population of systems to just help each other through the cost of, obviously, but also through the fact that there's not enough specialists within that field available to do what it needs to be done, especially in rural communities.
That model really works when you do have specialists, though, but the need is so widely dispersed. When we're talking about genetics counselors and the national shortage that we have and the increased demands that are coming, it really fits like a telementoring model. This is like a great Project Echo kind of approach where you can build capacity at your sites by partnering with. We have a Project Echo for genetics counseling for breast, where they partner with the nurse practitioner at the sites and are trying to build capacity that way. Because there's just like no way in Western Kansas with, many of our counties have a population of less than 6 persons per square mile. They're never going to have the patient base to support a practitioner like that. So there's that issue, but then there's also the issue of just the flat shortage and having to build capacity throughout our state in the western part of Missouri. And that's where really like the whole ECHO concept there. And again, democratizing the information. And that's such an interesting approach that I think we're going to have to become accustomed to if we're going to make sure that, at least in my area, it's the rural sector. So big, strong push there, but we're going to make sure they have the same kind of care. We're going to have to think about empowering people that aren't necessarily the experts to learn and build capacity.
I heard veiled comments, I think, about 23andMe and a few of the others. Do you think that 23andMe, obviously its real business model is to sell huge amounts of data to large pharmas, right? But its opportunity is to possibly fill this gap. I'm curious as to whether you think that kind of service model might also address this, were they to go down that, or do you think that that is not ethically or commercially viable? Does anybody have any opinions?
If you talk to a GC, they say 23andMe.
I'm sorry, could you bring your microphone a little closer?
I can.
Thank you.
If you talk to a GC, they are just adamant about this 23andMe. They don't like it at all. Yeah. It also doesn't afford the patient the opportunity. There are so many genes now that are coming out, and the 23andMe is restrictive. And they may have chosen a different test because of their family history or their algorithms, etc. So So I think utilizing the expert, I think it does a disservice, actually, to be honest with you.
Mhm.
And I think if the GC were here, that would be their opinion.
Very interesting.
Would you say that in the case of a Myriad too then? Because one of the things that was being
That's
said
right.
was the GCs go to Myriad helps, but it sounds like you would say that that's still an issue.
No, I think they like the choice. Their expertise is to take the history of that patient and understand what's there and what opportunity they have. And they want to be able to make sure that they're going to put the right test for that patient. Like they want to match it individually.
Right, but if a GC's at Myriad, they're going to push the Myriad tests, right?
Well, that's exactly right. So that's not ethical really, right? So when you talk about pooling resources, they would have to remain independent from these labs because that would just create bias, right?
You know, in my interview with Gary, I got an overwhelming sense that the breadth of what you've done, partially because the program is long-lived, you've had it running for a long time, but there was a broader area of applications that, as we talk about case studies, maybe you could address. Things, obviously, that are quite different than just genetic counseling, or as specific as, for example, a CAR T toxicity evaluation. Could you speak a little bit about sort of the broader applications at your institution?
Right. Are you talking about oncology?
Oncology in general,
Specific
yes.
or other disciplines?
Well, and also
altogether?
how it's spread into some other disciplines, because
Yeah.
it is interdisciplinary.
Yeah, I think a lot of it really comes down to, I got a kick out of your slide at the beginning when they were talking about the challenges with telemedicine, because it's been the same challenges for the last 25 years, really. I mean, they haven't really changed a whole lot. And even though the technology has advanced so rapidly, the diffusion hasn't been what many of us thought it would be quite some time ago. And I think it still comes down to the whole people perspective. And I don't know if this is really answering the question you want, because I think you may want more specific kinds of services, but it's about building relationships with different groups in whatever area you are serving, and then using the technology to provide that service locally. And it still comes down to the people factor. And even with everything else we're doing, I just assume my kids will be really different. My kids, I used to think were kids. Now they're all adults. And I wasn't kidding when I said I FaceTime with my youngest one yesterday with a sore throat. I mean, their needs for that interactive video may not be the same as the patients that I have served over the last 20 years. That video piece and that human connection was still a big piece of it. And I don't know, as we see their generation and those behind them, I don't know that they will have that same human interface need. I've always felt like in the cancer world that was still a really big piece of all of this. I had patients that in a tele-oncology practice over years that I had never met in person. And they were patients that I'd only met over the system and was their treating oncologist. But it all came down to the team that I was partnering with on the ground at that site. And that's how we were able to develop our economic models to sustain it. Again, where are we in healthcare delivery? I can't quite figure out where we are. At this point, it was all supposed to be bundled, right? But everyone still thinks in terms of fee for service and downstream revenue. So, I mean, if we're still thinking in fee for service and downstream revenue, you can make this work. If you have sites that are distant sites and you have, staff that can be the effector arms, you can justify this economically. From a health systems perspective, you can justify it. If you can provide services within one system and shift from one site to another where they specialize, you can make it work. But we're still to me, it feels like we still quite haven't figured out this model. And I just have to assume that Kaiser and what you do on the West Coast is a very different model than what I think we're still dealing with in the Midwest in terms of the fee for service piece. I haven't, and I'm a zealot, so I warned you, Mark, I'm a zealot. I don't think there is any part of cancer care that doesn't have some kind of application that could be telemedicine related, whether it's a patient that lives 7 hours from Kansas City that has a pre-op evaluation for a specialized liver procedure that they have to come to Kansas City for, then they go home and that liver surgeon does the follow-up work with the primary care team, who's probably a nurse practitioner, PA, probably not a physician in the most western part of the state. I just don't, there's just about there's an application for about everything you want to do. For me, it was all, I'm a medical oncologist, so it was all about getting patients what you need, and I didn't want them to get B care in the rural sector. So that meant working with their psycho-spiritual needs. So we had social workers that would meet with them by telemedicine, still do. We have a psychologist that specializes in cancer care that will provide services to the sites that we partner with. When I started practicing in Kansas City, now this is an age thing because I'm in year number 29, there were no psychologists that would see cancer patients. They're not bothered by them, but it wasn't their area. This whole psycho-oncology piece wasn't part of the landscape at that time. But now we have 8 on faculty at KU, and we have a couple now that are in private practice in the state. So wherever they are, trying to get them to connect up with. But whatever that comprehensive care is, we were talking a little bit about a hospice program that we have where we're connecting hospice nurses with patients and caregivers in their homes just using iPads. It's in the northwestern part of the state. It covers 16 different counties. It makes a lot of sense from a cost perspective. Each phone call is like $10 versus $140 to send them to the $140, $160 to send them to the home. We're covering 16 counties. There are 6 hospice nurses they don't live in one town. They're sprinkled throughout the northwestern part of the state. A lot of their team meetings are conducted by Zoom. Have figured out the technology such that they can initiate a phone call without having to schedule it with the patient. So they can call in and the iPad rings like a doorbell in the home of the patient. So they don't have to say, okay, call and say, I'll call you tomorrow at exactly 10 o'clock, be ready for it, right? They can just call in normally. I also think the workflow issue that you've talked about is a really good one. This is the last thing because I'm rambling. The workflow, just trying to, don't make the technology the center point. The workflow, make the technology fit the workflow, and then you'll get that provider acceptance. Whenever you try to make everyone work around the technology, with as busy as everybody is right now, if you give me one thing that's going to slow me down in clinic, I'm going to give you 10 reasons why I don't want to do it. So, right?
Robin, you talked a lot about it. Cancer Treatment Centers America, the importance of really understanding the business case and the relationship to the service lines and get those things sort of working. Those are all individual applications unto themselves. I wonder if you could maybe talk to us a little bit about what you guys are doing in those use cases or business cases.
Dr. Doolittle's, it's pretty
You're
good
gonna have to call me Gary.
Gary,
if your name was if your last name was Doolittle, would you insist on Dr. Doolittle?
I don't know. I kind of like it. I was kind of excited to say Doolittle.
There's a 2-headed llama actually out there.
Here we go.
Oh, that's good. Workflows have been a big piece, and I've been so excited for this conference, and everything is just all starting to click, and also thinking about what we need to fix and do better, takeaways from this. But I think our issue, and I'll be transparent, is we've been trying to work around our technology instead of working around the workflow. And so that has been a huge issue when it comes to processes and getting providers, even patients on board, because we are trying to work around this technology, even getting down to billing and coding. It's a huge, huge piece. And there's so many players involved, and nobody really understands all the players that are involved in a single telehealth appointment. So I would say, before you implement a big telehealth program, you really need to outline everybody that's going to be included, from the provider that's providing the appointment all the way down to the account specialist and the person sending the claim out the door. Workflow has been huge, and my big takeaway from this, and just talking to my neighbors, I'd be interested to even think about building our own internal technology out of a patient portal or something. It's been very educational.
So in other words, you're reaching the conclusion that an off-the-shelf system is not really going to work for you.
Off-the-shelf system is you making yourself available to the technology and building around it. That's essentially what you're doing, instead of you building around your internal programs and people.
Yes.
Yeah, I would say. Just a question to the group, kind of back to the super group you were talking about. Do you think that we'll be moving towards kind of contracting out, just thinking about resources and cost? I feel like that's kind of the direction we're looking at going, just having the resources 100% dedicated to telehealth. It's very hard to do in a hospital system. So I feel like I'm kind of seeing that trend, but are any other facilities seeing that you might be looking to contract out or use your existing resources?
I'm sorry, could you move the microphone closer? Thank you.
Dr. Williams with Children's might be able to speak to that.
I'm sorry. Oh, yeah. I was just curious if other facilities are looking to maybe contract out to providers that are 100% dedicated to telehealth visits versus using internal resources.
Yeah, so because we have so many different models at Children's, and because our kind of infrastructure is a little different. So we are Children's Health, the Children's Hospital of Dallas, but our clinical partner and our academic partner is UT Southwestern. So we don't own those providers. And so sometimes there's some reticence there on their behalf to lend their providers to do something that's not clinical work or taking time on their research. So we've been trying to figure out, we see the need for our patients. And so one of the ways that we are trying to figure out how to do that is to kind of contract out. One of the areas that we are looking into doing that is really with psychiatry and behavioral health. Yeah. The problem is that, those are typically for-profit companies. And so they oftentimes charge more than we would charge for or bill for. And so trying to kind of balance that out. But we are definitely looking at ways that we can do that because, like I said, it's one of those things where we see telemedicine and virtual health definitely as the complement that we need to healthcare. And, we all hear about this mental health kind of crisis that we're in and some of the other specialties as well. But again, you have to have the providers that are willing to do it. And when there is a model, like you mentioned, where providers can work from home or choose their schedule and decide how to really practice, then they're more likely to do it. Whereas, how do I fit it into my already existing very busy schedule? So, yeah. Thanks, Vicki.
I actually want to answer to that a little bit too, because, yeah, Gary, we're talking about Kaiser as a model, but I worked across many fee-for-services models as well at USC and UCLA and others. Two things, the rurality of a place definitely makes it a big challenge, but I think that Mark will agree with me that, if you live in the San Fernando Valley and you need to get to Cedars-Sinai for a treatment and you are a cancer patient, you are talking about 2.5 hours in your car, just the same, and very frustrated by the traffic. And usually by the time you're done parking, walking to your doctor, seeing your doctor and coming out, you're probably talking about a good 6 to 7 hour day, which not even a good LA person wants to deal with, especially when they're sick and vomiting. So the idea is that it's we are looking at this from 2 points of view. It's not just about what it takes for the patient, what the effort that it takes off the patient to get the kind of care that they need to get, and also being able to access the system. But at the same time, is who do they access when they finally do get there? I think a lot of time, it's not necessarily the actual oncologist or the actual person that they need to see. Sometimes they need to see multiple people. So I can tell you from my own personal experience with my own cousin who had severe ovarian cancer being cared for at Cedars-Sinai, we had specialists all over LA County that were taking care of her. None of them were talking to each other. None of them knew of each other. And her treatment plan eventually ended up falling apart and she ended up perishing. I think that a lot of time, if we could have pulled this team together somehow virtually, I'm sure people would be more than happy to have done that, even in a very non-rural community. But you're right that it has to make sense financially, right? It's always about the financial incentives for that. And I think that I was saying this to Ali and Lee before, you need to involve the drug companies in these conversations because they are ultimately the one who are making the bucks here, guys. And they're talking about a few $1 million, a patient. they should be getting involved in these conversations to see how do we improve patients' care, pulling in together resources. And to your point, Robin, you can get off the shelf a program, but you're still going to need to work through your workflow designs, understanding how that specific technology fits into that workflow design. And that's, by the way, what people like ours getting hired, just to let you know. We are coming into institution, looking at the entire workflow, mapping it out, and then deciding on a technology. And usually it's a third-party technology. It fits, but you have to design it from the get-go with that technology in mind. Yeah. So just to those 2 points. Right. Yeah. Sometimes you do. Yeah. Sometimes you do.
Just so you know, go ahead, please.
Coming from a system, a larger academic system, and UVA is by no way, shape, or form largest or larger. One thing that we have had to come to the realization, and this is from an IT perspective, is that you can have a core set of technologies that you're going to use, but that's not going to be the only set of technologies that you're going to use.
Yes.
We currently operate 5 platforms. And the reason we do is because we realize that not one platform is not going to fit all. Not one platform is going to give you every ounce of what you need. So we have to be agile enough as an IT department. And I say that with the caveat of we are not actually a part of IT anymore because of how agile we have to be.
Right.
But we have to build systems around specific use cases. We have to do it daily. We have to prove it daily. And so it's not always the off-the-shelf solutions can be beneficial, but what we found is that those off-the-shelf solutions are for-profit companies that are there specifically to make their profit, and so it becomes closed loop. One of the reasons we use so many platforms is because some of them work well with each other, and so we have them working in tandem.
Yes. And
then other solutions, if we need this set of tools, we have to use this and this only because we have no other choice. So, there's been some mentions about industry and how the technology industry and the healthcare technology industry is. Right now, it's all proprietary. Everybody wants their piece of the pie. They want their cloud solution. They want their peripherals. They want to make their buck. What we strive, or what I strive as an engineer, and so does the rest of my team, is how do we maintain interoperability? So that way, we have an FQHC partner that has 14 sites. They have their own telehealth technology that they have gotten through grants.
Yeah.
They talk back and forth seamlessly because we in the engineering side realize that we're not going to help their patients unless we do. So we've taken that effort to say, whatever you have, we will find a way to operate within without making our own clinicians learn 10 different systems. We try to streamline it, but it still has to be in that context of you have to use a little bit of everything.
I think that's well said. And I think it also informs how you select the vendors that you are going to work with, because there are some that are rigid and inflexible and will not achieve that goal. And there are others who are architecturally designed. And for example, one important area is many of the contemporary web-based telehealth systems are actually not web-based. They have what's called a TSR, or a little installation. Zoom does. Most of them do video, etc. They are moving towards something called WebRTC, which doesn't require any install and will run on any computer. And that is frankly the future, because you don't have one of the areas of interoperability conflict are these TSRs, where you may have one platform or another platform that have to run on the same computer, and they're trying to command and control the video at the same time. You know this. So those are the kinds of issues that can be skirted around when you move to a more modern contemporary architecture like WebRTC for audiovisual, and it does a lot of other things as well. One warning I would give you about building your own, and this is learned the hard way by many large healthcare systems, including Kaiser Permanente. You may recall before the war between Cerner and Epic for that business, they embarked on the build of their own EHR, and they spent, I think, $370 million, and it just landed like a thud. They couldn't get it done. The better technologies that are out there, they have 20, 30, $40 million invested in them. And they oftentimes still are only just basic video conference systems. So it's a major undertaking for a healthcare system to try and build out like this. I think that there are, as Siggy said, there's hope for COT software that can be modular and can help you solve your problem, but it needs to really be analyzed and designed properly. So I hope that's helpful.
I was just going to bring up one point
Yeah.
which I really appreciated Robin's discussion on, was the fact that as we're looking at this model for implementation, and as you have a hospital system, you may have a community clinic, you may have a larger community clinic across an area. In your case, Lee, in these cases, the question I'm seeing almost derived from this, and this is what kind of cautions me on this discussion, is if you have limited resources based on uncompensated care models, which is what we're talking about right now, because there's only 2 people who are actually making these calls who are not considered practitioners, are not billed for. That's genetic counselors, and that is pharmacists. And they're doing these calls as well. To some extent, it varies based on indication and also treatment therapy. So that is one piece. We don't have the billing ability for some of these practitioners, and we don't also have billing ability as well. So this is a major barrier. But the other piece, which really concerns me, that Robin brought up, and now I'm thinking about this and it's scaring me a little bit, is the fact that resources are an issue, right? We talk about psycho-oncologists, which is a clearly developing discussion. But if you have limited resources based on what you're doing, and if Sarah's calling that patient every day, is she getting compensated for it? And that may be a no, maybe part of her job, but it may be a no. Or maybe other people are too, and using grants to facilitate this and other means to actually pay for this. If we're going to a model which we want to pay for our services, which are critical, and we need that buy and bill discussion, I think that's one barrier on this piece. And the other discussion, which we've been talking about, but really haven't integrated into the immuno-oncology, but also the telehealth or tele-oncology discussion, is the fact that if we discuss buy and bill and we discuss value-based care, how do we get away from a silo of buy and bill based reimbursement for this service, which really can do a great amount of work, but then also have to address value-based care into these new modular discussions on how the future of payments will be directed. So I think, that's a barrier where I think we may see this evolution of private party services evolve. And I think that's, what I'm hearing a little bit, and also I'm seeing this discussion also evolve into. So just kind of remarking on that little piece as well.
Ollie, I think that you said something very important, and that we're seeing this happen. And this was true in the ACO model, which is essentially an early precursor of value-based care, is that when you're at risk, or when you're in that kind of closed environment of an accountable care organization and you're being compensated for results, adoption of telehealth increases dramatically because of all of the efficiencies that it can generate to produce better outcomes. And in a fee-for-service model, it's much harder to actually get adoption to grow. So to a degree, this shift that, of course, CMS is pushing for is probably one of the reasons why we're seeing an uptick. And it certainly has been true with the ACOs, especially the pioneer ACOs, because they got the greatest benefit from this. So it's now, believe it or not, 12:02, and I think we're ready to break for lunch.
Can I make one just quick
Yes, please.
So I echo a lot about the technology and the idea of making sure things are interoperable. And I think a lot of legislation that's gone through recently is going to really help with that. The one thing that I didn't think was talked about is it's not that these technologies don't exist today. They do. Think outside of healthcare, the types of things you can do. I think the legal framework is something that really needs to be thought through, because the big challenge becomes, as a vendor, you automatically have to put a BAA, even if it's just a video call that you're putting together. And that creates this bigger barrier of incentive and cost that just skews out the system, right? And I think it's important to kind of keep that in mind as well.
Absolutely. In fact, we've had some fascinating discussions with the doctors company, for example, about their view of this entire emerging field for healthcare and the incumbent liabilities that come with this, including the ability to ensure that if you are remotely monitoring a patient and you're getting a flow of data that indicates they're decompensating, does the providing organization have the workflows and systems in place to respond? Because if they don't, they potentially become liable. And yet the other side of the argument that I've heard from a number of doctors is, I don't want to know. I don't want to be exposed to the liability, because then I am obligated to respond. So this is a really interesting balance of ethics and performance of medical care that we're right on the cusp of right now.
Yeah.
You know. So, any other comments? Otherwise, we can break. Okay, lunchtime. Thank you all.